Great. Hello, everyone, and welcome to ADAA's professional webinar, Alternative Taxonomies to the DSM-5 with a focus on internalizing systems. Thank you, everyone here for joining us here live, and for all of us who are watching it recorded. We're so happy to have you here to share some amazing content. I would like to note that this webinar is being recorded, and for those who have applied for CEs who are joining us live, you have received an email prior to the webinar and you will receive a follow-up afterwards as well. I would like to introduce our wonderful presenter, Dr. Antonia Kazurkin. She is a licensed clinical psychologist and the director of the Brains Lab at Vanderbilt. Her research focuses on identifying neurobiological markers of internalizing disorders. She integrates multimodal measures such as neuroimaging and psychophysiology to develop a comprehensive understanding of the basic mechanisms underlying anxiety and depressive disorders. Antonia, thank you so much for joining us today. I'm going to hand this over to you so you can share your knowledge. That looks great on my end.
Okay, awesome. Well, thank you so much for having me, and I'm really happy to be here. So as I mentioned, I'm going to talk about alternative taxonomies to the DSM-5, but really with the focus on internalizing symptoms, because that's my area of interest, and that's the area that the ADA focuses on as well. So by way of overview, so first I'm going to talk about some of the advantages and disadvantages of our current classification system, the DSM. Then I want to talk about HiTOP as an alternative classification system that we might use to further our field. I'm also going to talk a little bit about understanding internalizing symptoms using a HiTOP framework with the goal of how would you actually use this framework in a clinical setting. And then finally, I'll wrap up with some conclusions and future directions. Right, so currently in its 5th edition, the Diagnostic and Statistical Manual of Mental Health Disorders contains specific diagnostic criteria and codes that summarize often complex conditions that we use in clinical research settings as well as in for insurance purposes. But how do we get here? So I just want to illustrate how far we've come as a field by giving you a brief history of our classification system. So the standardization of mental illness classification can really trace its roots to the late 19th century. However, classification of mental health disorders really took hold in the years immediately following World War II. So the US Department of Veterans Affairs needed a way to diagnose and treat returning service members who were coming back with a wide range of mental health difficulties. And in 1949, the World Health Organization released its 6th edition of the International Classification of Diseases, or ICD. And for the first time, they actually included mental illnesses. So the ICD-6 contains some of the earliest standards for mental health diagnosis. However, it was actually pretty limited in its scope. In 1952, the American Psychiatric Association, or APA, published the first DSM, the DSM-1. And this was an adaptation of a classification system developed by the armed forces during World War II. And the DSM was essentially designed for use by doctors and other treatment providers. So at the time, the DSM-1 was the first of its kind, but experts agreed that it still needed a lot of work. The DSM-2, which was released in 1968, was an attempt to expand the DSM-1, but also they wanted to incorporate the psychiatric knowledge of the day. So this particular version of the DSM was heavily influenced by psychoanalytic concepts that were really prominent at the time. The DSM-3 was published in 1980 and represents a radical change in the DSM structure. So the goal here was to improve the validity and standardization of psychiatric diagnoses. And it was the first version to introduce such elements such as the multi-axis system, as well as explicit diagnostic criteria. The DSM-3 also attempted to be a little bit more neutral with respect to the causes underlying mental health disorders. And they favored a more descriptive and kind of categorical approach compared to what they had before, which is more of a narrative approach. So although the DSM-3 was pioneering work, real world usage really quickly revealed a lot of flaws and limitations in the DSM-3. There was confusing diagnostic criteria, there was inconsistencies, and this led the APA to develop a revision. So this was the DSM-3R, released in 1987. And this revision fixed many of the kind of internal difficulties of earlier work. Then published in 1994, we have the DSM-4, which reflected numerous changes in the understanding of mental health disorders. We had some diagnoses that were added, others were subtracted or reclassified in an effort to make it more user-friendly. And much of the effort of updating the DSM-4 involved conducting a comprehensive review of the literature with the goal of establishing a more empirical basis for making modifications to the DSM. So the developers of the DSM-4 and the 10th edition of the ICD also worked very closely together to coordinate their efforts in hopes of having increased congruence between the two systems. The DSM-4 was further refined in a revision in 2000. Most of the changes were made to the associated feature sections of the DSM, things like cultural considerations, age, gender features, prevalence course, and familial pattern. However, the majority of the text was actually left unchanged in that revision. And then we have the DSM-5 published in 2013, representing another substantial shift in thinking about mental health classification. So in addition to changing, removing, or adding diagnoses, the organizational structure of the DSM underwent a major reworking. So as we all know, the multi-axis system was removed, as well as the Global Assessment of Functioning, or GAF scores. And the DSM-5 was reorganized with 6 classes of disorders. So 6 classes were added and then 4 were removed. And as a result of these changes, numerous individual disorders were reclassified from one class to another. For example, mood disorders, the category of mood disorders was removed. And now we have one class for bipolar related disorders and another for depressive disorders. We have the most recent edition, the DSM-5-TR, which was published in 2022. This is the latest text revision. It actually didn't include too many conceptual changes to the criteria sets, but some clarifications to certain diagnostic criteria were made, and that was just to improve clarity. So in sum, we've come a long way as a field. However, there's still much room for improvement. So before talking about how we might improve our classification system, I want to point out that there are a number of advantages to our current system. So I think we have a tendency to put down the DSM, but we are definitely better off now than we were before standardized classification systems came into being. So the DSM's description of diagnostic and associated features is an advantage. It's actually based on many, many decades of clinical experience. It also provides us with a common terminology for both clinicians and researchers that allows for the standardization of diagnoses across different providers. The DSM's standardized coding has also been very useful for insurance purposes, and various versions of the DSM have also been very responsive to the accumulation of new knowledge over time. So updates were being made as new information was emerging. The DSM is also useful for providing a framework for making treatment recommendations. And finally, the DSM has been harmonized with other commonly used classification systems, such as the ICD-11. So the DSM does have its advantages. Despite these advantages, increasingly, mental health researchers and professionals are considering the drawbacks of the DSM. And in order to understand these concerns, it's first kind of necessary to understand what it is the DSM is failing to capture. So there are 2 basic approaches that we can take to mental health classification. The first is the approach taken by the DSM and the ICD, which is a top-down or theory-driven approach. So in this approach, experts decide what diagnostic categories to include in our nosology based on theory, based on clinical observation, and just based on expertise. So this approach is subjective because we choose which disorders exist and what their symptoms are going to be based on expert opinion. In contrast, alternative approach is the bottom-up or data-driven approach. So using this approach, we actually start with the data. So we gathered large amounts of data on psychopathology symptoms and then used advanced statistical methods to understand the structure underlying our symptoms or our data. For example, we might examine whether the symptoms cluster together in meaningful ways, or we could determine whether the symptoms are showing a hierarchical pattern or not. So this approach is empirical because we let the data tell us where the natural boundaries, if any, exist between classes of symptoms. So the first disadvantage of the DSM is that it has a reliance on these subjectively defined diagnoses that are not empirically validated. The DSM is also based on the notion that mental health disorders represent discrete categories. And these all or nothing categories are often based on having a certain number of symptoms needed to receive the diagnosis, such as 5 out of 9 symptoms. And these are relatively arbitrary cutoffs. We have long known, actually, that psychopathology symptoms exist on a continuum from health to impairment, suggesting the existence of dimensions rather than categories. And the recent focus on dimensionality in our field is really about returning to our roots of viewing psychopathology as a spectrum from no symptoms to many symptoms. So dimensional models are useful because they take into account subthreshold symptoms that might otherwise be disregarded if we only look at the extremes. So dimensional measures that take into account the entire spectrum are going to be more representative of the actual presentation of psychopathology symptoms in the general population. So the second disadvantage of the DSM is that diagnoses are based on categories when psychopathology is actually dimensional. In addition, as we're all very well aware, comorbidity, or the simultaneous presentation of 2 or more mental health disorders in our patients, is the rule rather than the exception. So among those with a mental health disorder, approximately 55% have 1 mental health disorder, but 28% have 2 mental health disorders, and 17% have 3 or more mental health disorders. So high comorbidity across disorders is very common, especially for certain types of disorders. For example, we know that the chances of having both an anxiety disorder and a depressive disorder are very high. Given the high comorbidity that naturally exists between disorders, the simultaneous occurrence of symptoms in the same patient may actually inform how these disorders are related. However, the DSM does not currently use comorbidity rates to develop its nosology. To be fair, the DSM does allow for the existence of comorbidity. For example, the DSM actually has sections for each disorder where potential comorbid disorders are discussed. So it's not that the DSM doesn't consider comorbidity. The issue is that the information on shared symptoms across disorders is not used in any way to inform the classification of disorders. So the third disadvantage of the DSM is that shared symptoms between diagnoses are largely ignored. Lastly, there is considerable heterogeneity within psychopathology symptoms in terms of both symptoms and neurobiology. So 2 individuals with the same diagnosis could have widely different symptom presentations and potentially different underlying neurobiology. So this figure here shows the symptoms assessed by 7 different measures of depression, which are abbreviated across the top there. There were about 34 symptoms that were common across these measures, as indicated by symptoms that are associated with multiple colored dots. And we can also see heterogeneous clusters of symptoms that differentiated between measures of depression. And altogether, this particular study found 52 individual symptoms of depression. So as you can imagine, there are many, many combinations of these symptoms that could lead to a diagnosis of depression, suggesting that significant heterogeneity exists even within a single class of symptoms. So heterogeneity is definitely allowed in the DSM. A patient can have different combinations of underlying symptoms. The issue here is that information about heterogeneity is actually not used to guide the nosology. Additionally, the DSM actually treats disorders as homogeneous entities. So for example, a patient with anhedonia, insomnia, suicidal ideation, feelings of worthlessness, and psychomotor slowing is going to get the exact same diagnostic label as a patient with sadness, appetite changes, feelings of guilt, concentration problems, and psychomotor agitation. So the last disadvantage of the DSM that I want to point out is the lack of consideration of heterogeneity. Right, to sum up the kind of first section of our talk here, again, to our list of advantages, we have some disadvantages as well. So the DSM uses subjectively defined diagnoses that are not empirically based. It's based on categories when psychopathology is dimensional. It ignores subthreshold symptoms by using all or nothing categories with arbitrary cutoffs. The DSM discusses comorbidity, but shared symptoms between disorders are largely ignored in the formation of the nosology. Finally, the DSM allows heterogeneity within diagnoses, but does not use this information in any way to guide diagnosis or treatment. Instead, disorders are treated as homogeneous groups. So in light of the concerns with the DSM, there is actually now a movement in our field to redefine our mental health classification system. So the hierarchical taxonomy of psychopathology, or HiTOP, is an empirically derived model of the major dimensions of mental illness. And it represents an alternative research paradigm that has multiple advantages over our traditional categorical DSM. So before I introduce the model, I want to give you a little bit of a background on how this model was actually made. So given the dimensional and highly comorbid nature of psychopathology symptoms, there's been a growing recognition that the diagnostic categories defined by the DSM may not be capturing the natural boundaries between mental health disorders. And now we have a movement to redefine our taxonomy using a data-driven approach. So one way we can do this is through statistical modeling. So to do this, we start by simply using exploratory factor analysis to determine how symptoms naturally cluster together. So in this very simplified schematic, I'm only showing you 9 individual symptoms, but a typical model could easily have 100 or more psychiatric symptoms. So when we do this, what we find is that symptoms don't cluster into traditional DSM diagnostic categories. And instead, we find things that are different. We find things like mania actually has closer ties to psychosis than its own family of mood disorders. So we can use this exploratory process to determine how the symptoms group together, and then we can start to explore more advanced models. For example, research suggests that psychopathology symptoms may be better represented as a hierarchy, with a general psychopathology factor, also called the P factor in the literature, representing the symptoms that are shared across disorders. So many studies at this point have demonstrated that psychopathology symptoms can be organized in a hierarchy. And in addition to a general factor of psychopathology, or P factor, representing that which is common across all psychopathology symptoms, these models also define specific factors, which, depending on the type of model you use, can tell us something about the unique variants attributable to each class of symptoms. Right? So as a field, we're moving to using these statistical methods to identify hierarchical models as an alternative way to classify psychopathology symptoms. So HiTOP very much used this approach. So this is one version of the HiTOP model. There are actually a couple figures out there right now. They have slight variations, and they've been updated over time as new information has come forth. So here, the HiTOP model shows both broad and narrow dimensions. And this is very important for many reasons. So we start actually, I don't know if you can see my pointer here, but we start at the very top with the super spectra, which is again, that general factor, that P factor that is common across all symptoms. Then we actually break it down into what they call spectra, which are the kind of classes of symptoms that group together most commonly. So most often these studies find an internalizing factor, they'll find a thought disorder factor, sometimes it splits into thought disorder and attachment. And then they'll often find an externalizing factor, which is more and more commonly being split into disinhibited externalizing and antagonistic externalizing. From this level of spectra, we can move down into subfactors. Within the subfactors, you will see that there are some new terms, things like distress and fear, And there are some common terms, things that you've seen before, like antisocial behavior, substance abuse, and mania. So the subfactors represent the next level of detail in our model. Within our subfactors, we're going to see a little bit later today that there's actually a lot of individual disorders that fit in symptoms that fit into each of these subfactors. I just want to show you a brief overview of how the HiTOP system, shown here on the top half, and the DSM align at this point. So importantly, we're including the DSM on this figure just for illustration purposes. I think one confusion that people have is that we actually have the DSM diagnoses within the HiTOP model, and that is not the case. When we have the DSM and the HiTOP next to each other, it's just for illustration purposes. We're not saying that these are actually where we're going to end up in terms of the HiTOP disorders that come out. But just to give you an idea with some labels that are more common, so you can see here in the mania section, we have the bipolar disorders. Distress has things like dysthymia, which we now call persistent depressive disorder, major depressive disorder. The fear category has things like agoraphobia, OCD, panic, and some other disorders as well. So this is the overall kind of HiTOP framework. We're going to get into more detail in a little bit about, in particular, the subfactors and what's inside there. Okay, so here we have the HiTOP as just a model. However, as the model came out, a number of misconceptions came out along with that model. So a number of individuals have raised concerns about this model. And what I want to do next is actually address some of those concerns. So the way I'm going to frame this is actually to talk about 7 concerns that actually are not well-founded in terms of understanding this model. So I'm actually going to talk about them as myths. All right, so myth 1, HiTOP classifies people. So HiTOP is sometimes misunderstood as a system for classifying people. And actually what the model classifies are signs and symptoms of psychopathology. So by symptoms, I simply mean, observable signs and subjective symptoms. For example, anhedonia might be one of the symptoms that we observe in patients. So the idea here is that we're going to take a comprehensive list of these symptoms, and we're going to see how these symptoms cluster together. In that way, HiTOP is actually taking a variable-centered approach to classification rather than a person-centered approach. So the symptoms are grouped into a hierarchy of dimensions according to their likelihood of occurring in the same individual. So this figure is the same HiTOP model I just showed you before, but with greater detail about the symptoms that make up each spectrum. So importantly, this model is based on the best available data we have now. If it's found in future research that a symptom is more closely aligned to another spectra, we can update this model to reflect that. So this variable-centered approach that the HiTOP model is taking is very different from the DSM. So the DSM classifies people into discrete categories. You either have a disorder or you don't. In HiTOP, people are not classified. They are simply described by their position on each symptom dimension in the framework. So this model does not fit people into one of these spectra or subfactors. That's not what it's doing. Instead, patients can exhibit elevated scores on multiple dimensions. So in other words, a patient isn't represented by a single dimension, but by a profile across all dimensions, reflecting the relative contributions of many domains. And we're going to see how that actually works in practice a little bit later on. Right, so in sum, the myth that HiTOP classifies people is actually incorrect. HiTOP classifies symptoms, not people. Right, myth 2 is basically that descriptive nosologies in general are not useful. And this is not specifically directed towards HiTOP, it's more towards all descriptive nosologies. So the assumption here is that because HiTOP is purely descriptive, it is not likely to be useful, and that's not exactly accurate. So it is true that a nosology based on valid theories of etiology or kind of causal mechanisms would be more useful than one based on description alone. That is true. But an accurate descriptive nosology is still important to advancing our understanding of mental health disorders, even before we have a clear etiological understanding of those disorders. So we can take as an example the medical field. So in the medical field, we have a definitive understanding of the causes of certain illnesses. Despite that, the medical field still relies on symptoms as their starting point. As a case in point, we have a very precise understanding of the etiology of COVID-19, right? So we know that coronavirus or COVID-19 is caused by an infection with the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. But we don't test everyone on the planet for COVID-19. We wait until there are symptoms such as cough, shortness of breath, difficulty breathing, fever or chills, muscle and body aches, vomiting or diarrhea, and or new loss of taste or smell. So the medical field readily acknowledges that these symptoms could indicate many different illnesses that are not COVID, but these symptoms are nonetheless a critical starting point for determining who should be tested further. Likewise, we don't have a definitive test of mental health disorders. None exists, except for maybe a few chromosome-linked neurodevelopmental disorders. But symptoms are still critical for us as a starting point to understand what is going on with our patients. By understanding our patients' symptoms across many domains, we can begin to narrow down where we should be assessing further. And understanding the symptoms that are most likely to go together, to cluster together, can help inform etiological theories that we can later test. Additionally, the use of descriptive nosologies in our field is not new at all. We've long used very similar descriptive taxonomies to describe things like personality disorders. For instance, if you've ever used the MMPI or a personality test based on the Big Five, you've used one of these systems. And these descriptive classifications have proven very useful in our field, even though we don't have a clear understanding of the causal mechanisms underlying personality disorders. We still find these descriptive classifications very useful. So not only are descriptive nosologies useful, as a field, we lack a comprehensive, empirically derived descriptive system of mental health disorders. And that is why the HiTOP consortium was launched. So the consortium acknowledges that descriptive symptoms are only a starting point, but the hope here is that we can use this descriptive nosology to inspire theories on etiology for these particular disorders. So taken together, the myth that descriptive nosologies are not useful is incorrect. Accurate descriptive systems can be very useful for inspiring new theories about causal mechanisms and can complement our existing etiological models. All right, myth 3 is that HiTOP is atheoretical, meaning it's not based on pre-existing theory. So HiTOP is data-driven. That is true. We let the underlying patterns of the data drive discovery of the dimensions. However, that doesn't necessarily make it completely atheoretical. So all scientific endeavors involve theory, including HiTOP. For example, HiTOP proposes that data-driven dimensions will more accurately capture comorbidity among disorders. The model also relies on the theory that the co-occurrence of symptoms within individuals can inform diagnosis and treatment. And in addition, HiTOP's proposal that mental health symptoms form a hierarchy as opposed to some other kind of unranked formation is also a theory. So there are actually many theories within the HiTOP model, and those have subsequently been tested to actually rule out other theories. For example, early on, Kotov and colleagues compared the ability of 7 models to account for associations among 25 psychiatric conditions, and they tested several alternative groupings of those disorders. And what they did is they found that the DSM-defined model actually fit the data very poorly. Instead, the best fitting model consisted of 5 factors, which are shown here. So those were internalizing, externalizing, thought disorder, as well as somatoform. So the model presented in this paper has undergone further refinement over the years, but the point here is that HiTOP really began with the theory that psychopathology may be hierarchical, and this theory was subsequently tested. So the point here is that HiTOP is not completely atheoretical, but it is predominantly guided by data. And the benefit of this approach is that this model is very flexible. So as new data comes to light, the model can be adapted as new constructs emerge. Right. Myth 4 questions the validity of the HiTOP model. So some have been a little bit skeptical about the ability of this model to aid in scientific discovery. However, these concerns are actually unfounded. If anything, what we're seeing is that the HiTOP model results in better precision than the DSM diagnostic categories. So both structural and validity evidence are considered when evaluating the HiTOP constructs for inclusion. And the dimensions that HiTOP has identified have been shown to consistently appear across many different data-driven studies. So validation of the HiTOP spectra is ongoing, but it's already produced a substantial body of evidence showing quite a bit of external validity. So we're starting to see studies showing that these constructs capture information about common risk factors, about treatment response, things about biomarkers, as well as genetics. For example, a number of studies suggest that environmental exposures, such as childhood maltreatment and discrimination, are risk factors for a lot of the HiTOP dimensions. And it's been found that the HiTOP has been a better predictor of risk than actually the DSM disorders. Additionally, the efficacy of many treatments, such as antipsychotics, SSRIs, and various psychotherapies, actually aligns with the HiTOP spectra in quite a bit of ways, in a number of ways. Research on the neurobiological mechanisms underlying these constructs also points to the utility of using this model to identify biomarkers. In terms of genetics, we're seeing robust associations that have demonstrated many genetic polymorphisms and behavioral phenotypes that are associated with these dimensions. Further, studies have directly compared the HiTOP spectra to DSM diagnoses in the same data sets and have consistently found that the dimensional and hierarchical assessments lead to discovery of a larger number of potential polymorphisms and are more predictive of polygenic risk than the DSM. In addition, substantial evidence from twin studies and molecular research indicates that genetic associations among different forms of psychopathology really largely parallel HiTOP's organization. So taken together, we're seeing ample evidence, not only for the validity of the HiTOP constructs, but also for the better predictive ability of HiTOP over the DSM. Right. Myth 5 is that HiTOP is not falsifiable. So a scientific theory is only useful if it's falsifiable, meaning that we can test its assumptions and confirm or refute the model's predictions. So theory falsifiability is an ongoing process. It involves generating research questions and developing hypotheses, which we then test in an empirical study. And based on the results of that study, we can evaluate the accuracy of our predictions and revise or update the theory as necessary before starting that process all over again. So the notion that HiTOP is not falsifiable is actually incorrect. So HiTOP is very much falsifiable, as much as possible when we're dealing with mental health concepts. So there are very few psychological constructs that we can definitively prove or as true or false. But the idea that HiTOP is not testable is not accurate. So I already mentioned earlier how Kotov and colleagues have compared the ability of several different models and showed that certain models demonstrated better fit. So that was a clear empirical test of these competing theoretical models. And in fact, most studies supporting the HiTOP model use methods such as structural equation modeling, taxometrics, and other hypothesis-driven analytic procedures to test their specific hypotheses or compare alternative hypotheses according to the fit of the data. So the idea that this measure is not falsifiable is not accurate. And beyond testing different models, the elements of the model itself can be considered as potential hypotheses. So I showed you this HiTOP figure earlier. Each symptom placement could become the basis for a testable hypothesis. For example, hyperarousal is currently part of the distress subfactor, but if sufficient data indicated that it shared closer links to fear, it could be moved into the fear subfactor instead. Additionally, some elements of the model, such as somatoform symptoms, are often represented as provisional in this model. You can see that by the dashed lines, because more research is needed to determine whether somatic symptoms should form their own distinct dimension or not. So there's a hypothesis there. You can also see that mania has an intermediate position between internalizing symptoms and thought disorder. And this is represented with the dashed lines, reflecting its kind of provisional nature in its placement. So when we take this all together, we can generate hypotheses about any particular element in the HiTOP model, test those hypotheses, and refine the model to accommodate new information. So in that way, HiTOP is very much falsifiable. Myth 6 asserts that the HiTOP model is not generalizable. So this one does have a little bit of truth to it. So generalizability, or the extent to which this model is kind of reflective of the structure of psychopathology in the broader population, both across groups and across the globe, is an important concern, but it's a concern for all mental health assessments that we currently use, and not just HiTOP. So on the one hand, there is some evidence of the generalizability of this model. So the HiTOP model is based on studies with samples spanning age ranges from 2 to 90 years of age. A number of studies also include non-Western societies. So Kotov and colleagues in 2017 summarized the literature and found numerous cross-cultural studies that use the HiTOP model. They have also shown studies that look at the HiTOP model amongst understudied populations. For example, HiTOP consistent measurement has been used to disentangle biases in the assignment of borderline personality disorder diagnoses among sexual and gender minority individuals. So it's certainly true that more work needs to be done in this area to determine the applicability of the HiTOP model to diverse populations. But this is also true of all psychopathology models generally. Western samples in our field are overrepresented in the literature, and there's actually very little research that's been done on people over the age of 60. So to address this, the HiTOP Consortium has developed a working group. This is the developmental working group, as well as the diversity, equity, and inclusion working group, to seek additional data to fill these gaps in the HiTOP model. So what they're interested in doing is actually expanding their model to more diverse populations and understanding what are the demographic and cultural differences that appear in this model, and do we need to adapt it or revise it? So the goal here is to increase the generalizability of this model. We're not quite there yet, but there is definitely work being done in that area. The last myth that I'm going to mention is that the HiTOP model is not clinically usable. So it has been suggested that there is no way for clinicians to assess the HiTOP model effectively or use it in their practice. And that is actually not true. So HiTOP was actually been shaped in part by research on measures such as the Child Behavior Checklist and the Personality Inventory for the DSM-5. HiTOP actually aligns very well with widely used instruments that many clinicians find very helpful in their practice. So the consortium is actually recommending a number of these instruments for assessing certain elements of the model. And many of these measures have established norms and clinical cutoffs. However, what we don't have is a single measure that covers all of the HiTOP spectrum. So to that end, the HiTOP Consortium has developed a measurement development working group, which is constructing the first comprehensive inventory for using the HiTOP model in the clinical setting. And this is actually expected to be ready within the next few months, if not sooner. Right, so we're developing a model now. They've identified a number of items and symptoms. They've constructed these lists and conceptual definitions. They've built up a really comprehensive item pool. They've collected data. They're cross-validating this in new samples, finalizing the scale. And then as part of phase 3, they're going to be doing some external validation, as well as developing norms. And then again, importantly, translating to other languages so we can start to get more data in diverse populations. So while that is all ongoing and going to be very, very soon available for practice, meanwhile, the clinical translation work group has actually assembled a battery of existing self-report measures that can be used to assess most of the model. And if you take this battery of measures, it takes about 40 minutes to complete. The battery is free, it's self-administered, and is automatically scored. And you can use that battery to get an approximation of the HiTOP model while you're waiting for the measure to come out. The work group has also developed manuals, training sessions. They've got online resources to really help clinicians with the practical implications of using this model, including questions about billing. So this battery is currently being used by a number of studies to assess the clinical utility of the system. And really, the kind of main objective of the HiTOP consortium was to make a nosology that is going to be useful for clinicians. So that was a primary goal. So we actually have 3 types of evidence that support that aspiration. So first, HiTOP dimensions show substantially higher reliability than DSM diagnoses. There's several studies showing that these dimensions account for about twice as much variance in crucial clinical variables, things like functional impairment, service needs, risk for suicide attempts. So these dimensions account for quite a bit more variance than the DSM. And third, surveys of clinicians have generally found that they see more utility in the HiTOP dimensions than in the traditional DSM diagnoses as well. All right, so the myth that this is not going to be clinically usable is not well founded. Right, so just to summarize, to this section, we actually have 7 realities about HiTOP. HiTOP classifies symptoms, not people. Descriptive nosologies like the HiTOP are useful. HiTOP is driven by both theory and data. HiTOP has demonstrated external validity. HiTOP is empirically testable and refutable. This model's generalizability is currently being worked on and improved. And HiTOP is useful in clinical settings. Right, so to wrap up here, what I want to do next is actually provide you with a framework for using the HiTOP model to understand internalizing symptoms. So the Diagnostic and Statistical Manual Mental Disorders is used by us to understand the characteristics, determinants, underlying pathophysiology, and recommended treatments for mental health disorders. And an up-to-date taxonomy is really important because it reflects our kind of prevailing knowledge about each of these disorders, which is critical for advancing our understanding about the shared underlying mechanisms, as well as understanding targets for therapeutic change. So the most recent updates to the DSM did substantially reorganize the anxiety disorders to reflect the latest evidence regarding commonalities and distinctions between these disorders. For example, as we all know, obsessive compulsive disorder and post-traumatic stress disorder were determined to be distinct in terms of their etiology, their symptom presentation, and their underlying biology from what they now call the anxiety disorders. So those 2 disorders were moved into separate sections in the DSM. Despite these improvements, problems remain with the classification of internalizing disorders in the DSM. One of the problems is that we still consider depressive disorders separate from anxiety, which is separate from OCD, which is separate from PTSD. So we know that there's actually really high comorbidity among the internalizing disorders. So here I've just listed some of them, but basically the idea here is that major depression is very, very highly comorbid with what we refer to now as the anxiety disorders. It's also very highly comorbid with OCD, and it's also highly comorbid with PTSD. So we may be doing ourselves a disadvantage by simply separating OCD and PTSD into their own sections, keeping major depression in a separate section, and then kind of lumping the anxiety disorders into another section. When we actually look at the individual symptoms that make up many of these disorders, what we see is that there's actually quite a bit of overlap. So here I've got the anxiety symptoms on the left and depressive symptoms on the right. And in the middle here are some of the symptoms shared by both anxiety and depressive disorders. Things like irritability, concentration problems, fatigue, restlessness, trouble sleeping. So there has been a recognition in the field that there is a lot of overlap between these disorders. And in particular, this has inspired some individuals to reconceptualize how it is that we are classifying internalizing disorders specifically. Right. So a very seminal paper that was produced by Kruger in 1999. Actually, was one of the first papers to use this kind of data-driven approach to understand how symptoms cluster together. And what they found, or what he found, was that internalizing symptoms actually break down into two dimensions. One, which is called fear, often in the literature, and the other, which is often referred to as distress. In some of the papers, it's called anxious misery, but it actually is the same thing. So distress is the same as anxious misery. Right? So within those two categories, we see a further separation in that fear includes things like social anxiety, specific phobias, agoraphobia, and panic disorder. And the distress factor included things like major depression, persistent depressive disorder, and generalized anxiety disorder. So this was a surprise back in '99 that generalized anxiety disorder didn't fall into the fear category, right? So for a long time, GAD has been thought to be anxiety disorder. So what we actually know now is that GAD, which we all know is a very debilitating disorder involving significant rumination and worrying, GAD has really been the focus of a lot of debate regarding its rightful place among the internalizing disorders. And this is not new. This has been occurring over the last 20 years. But what we're seeing now is that in addition to this Kruger study, many factor analyses have consistently shown that GAD symptoms cluster with the depressive disorders, forming that distress factor, which is distinct from the fear factor. This could be due to overlapping symptoms between GAD and MDD. There could be shared risk factors and underlying mechanisms that contribute to this. And as a result of this, there have been calls to actually redefine how it is we define these disorders. So if you were to look at the DSM right now, generalized anxiety disorder still remains in the anxiety class, so the class of anxiety symptoms. However, we have lots and lots of empirical research from many years showing that GAD actually groups itself with depression. It has more in common with depression than with the fear disorders. So this alone tells us that our current nosology has failed to keep pace with the accumulation of empirical evidence regarding the relationships among internalizing symptoms. Right, as a result, the HiTOP model, if you look here, we've got the, again, similar version of the figures I've shown you already. We've got the superspectra, spectra, and subfactors. As you can see, within the HiTOP model, generalized anxiety is actually included in distress. So the HiTOP model already has taken this literature and adapted their model so that generalized anxiety disorder is now shown to have more in common with major depressive disorder and persistent depressive disorder. So this is a huge advantage over our DSM, right? So we've let the data tell us where GAD fits in our model, and then we adapt our model and we put it where it is most relevant. And that can help us in the future to understand the etiology underlying the disorders. It'll help us to understand, what are the treatment recommendations. Maybe the class of distress symptoms requires slightly different treatment recommendations than the class of fear symptoms. And this in turn is going to advance our field and allow us to have a better understanding of how these disorders are related to one another. So all of that is just to say that we are moving in the right direction with this model. We are allowing the data to tell us where disorders and symptoms fall, with the idea that this will be a modifiable system that we can use in the future to better understand psychopathology symptoms. Just in case you're curious, how would you actually use this in clinical practice? What would that look like? So essentially, you would give the measure, which again is going to be released in the next couple months or less. You would give that measure, not unlike you would do with like an MMPI, right? So you give the MMPI, you get back a profile, and the profile might look something like this. So what you'll see is that you have all your dimensions. They're broken down into the spectra as well as some of the subspectra. And what you can do is simply kind of glance over this and very quickly pick out what are the major problems and issues that your patient is bringing to the table. So this was a patient with substantial internalizing symptoms. And as you can see, I know the font is a little bit small, but as you can see, under the spectra, some of the highest T-scores we have are things like functional impairment, internalizing, and somatoform. Within the internalizing domain, lots of things are elevated. Some really, really high things are things like insomnia and suicidality, right? So that's suggesting we need to really assess for that very carefully, self-harm. We can also look at some of these other dimensions, and we can see there's almost nothing in the antagonistic externalizing section, very little in the thought disorder, and not much in the detachment either. So very quickly, what this model is going to allow us to do is to identify where it is that we need to focus our attention. So where do we need further assessment? Where we can start generating hypotheses about what is going on with our patient, and we can follow that up with our clinical expertise to really fully understand what is going on with their patient. Right. So that is how you would use the HiTOP in a clinical setting. Lastly, I'm just going to very quickly give you some broad conclusions of future directions. So as a whole, the HiTOP consortium has taken many strides, but this work is only beginning. There is still much more we need to understand, and we need to continue building and refining this model. But if we continue to do that, our hope is that a more valid and useful nosology is actually going to benefit our entire field, including researchers, clinicians, as well as trainees. So the idea here is that we're hoping that this model is going to reinvent the way that we think about psychopathology symptoms from a more empirically based standpoint. With that, I do want to put a little bit of a plug that if you're at all interested in following the HiTOP groups or even joining one of the HiTOP working groups, there are a number of groups available for you. I've got the website here. We've got quantitative methods group. There's a normal personality working group. The utility working group is really about trying to see how the HiTOP model informs prediction and kind of explanation of mental health. There's a clinical translation working group. There's a measure development group. I'm part of the Neurobiological Foundations working group. There's a genetics group. The revisions group is one that's going to be very important for changing the model and updating it over time. And there's a developmental working group because we recognize that right now, this model does not include a lot of disorders like neurodevelopmental disorders like autism. And that is something that group is actively working on. And then finally, we have the diversity, equity, and inclusion working group, which is going to be very important to taking this model and making sure that it is as generalizable as possible. All right, with that, I will open it up for questions.
Thank you so much. That is really interesting. I just want to start off with a question. This does break things down in a way that may be helpful for someone who is struggling with mental health to be able to kind of categorize their thoughts and their experiences. Have you guys considered exploring the access to care aspect of it and discussing it with someone who is going through treatment, and if this clarifies their ability to communicate their diagnoses?
Yeah, that's a great question. So we have not gone that direction yet. So once we have the measure finalized and out, the plan is to open it up for clinicians to start using, for researchers to start using. And at that point, we're going to start gathering a lot of feedback. And that's exactly the kind of feedback we want. Does this help inform your practice? How are patients responding to these new ideas? How are you explaining this model to your patients when you administer this measure? So those are all future directions that we are definitely very interested in learning more about. So we invite feedback. We invite people to use it, use the measure, and give us lots of feedback about how useful it is in practice.
That makes sense. Are there any challenges that you guys are still kind of overcoming and working out the kinks of?
Oh, tons and tons. So I'm not in actually the measurement working group, so I can't speak to the exact challenges that they're facing, but as a part of the global consortium, I can tell you that, yeah, there are many, many challenges. This is just the beginning. So as you saw in some of the figures I showed you, some of the categories like somatoform are not finalized. It's not clear whether there should be a somatoform category or not, or whether we should actually be subsuming those symptoms into other categories. So there's lots and lots of questions. I think the biggest challenge that we're going to face is actually in getting people on board with the model in terms of billing purposes. So I think that is the biggest fear of the HiTOP model is, people understand data-driven is closer to the data. It's actually going to be a little bit more accurate. People appreciate the model, they can understand the model, but I think there's a fear that, how am I going to use this in terms of billing for my patients? So as a working group, what we're going to do is actually create more kind of more like manuals in terms of like how you would actually use this model in clinical practice, how you would bill with it, and how you would explain this to your patient. So that is forthcoming. I think that is going to be our biggest challenge going forward, though.
That makes sense. In terms of psychiatry, how would this kind of align with medications for patients?
Yeah, so the hope of the HiTOP model is that it'll be very much useful in psychiatry as well, that psychiatrists could use this model to understand where are the most debilitating symptoms for their patient. And part of the impetus of having a HiTOP model at all is to inform research on treatment, right? So we have a better understanding of how these symptoms cluster together. We're going to be better at being able to identify targets for treatment. So for example, I give the example of how GAD is actually right now in the anxiety disorders. And in most of the anxiety disorders, we use exposure-based therapies. However, one of the front lines of treatment for GAD is actually SSRIs, which is very much aligned with the fact that GAD has a lot in common with the depressive disorder. So if we have a better nosology, our research that comes out identifying targets for treatment is going to be more accurate, and that is going to definitely facilitate medication as well as psychotherapy treatment.
That's fascinating. For all of our listeners today, is there anything you want them to take away, a key point?
Yeah, so I think the key take home is to not be afraid of the HiTOP model. I think there's an inherent resistance to change, but I can tell you right now, this is a good change. This is the way that our field wants to go. We want to move away from kind of the systems in which we kind of subjectively define these disorders and we didn't really empirically validate them. I think we're beyond that now. So we have the data, we have the tools, we have these statistical analyses to do something much more refined, much more accurate, and ultimately is going to be much better for our patients in terms of diagnosis, the accuracy of diagnosis, as well as identifying, targets for treatment. So don't shy away from HiTOP. It's not going anywhere. Read more about it. I've got lots of references in the slides that I will provide for distribution. So and there are a lot of these references are geared towards clinicians. So those who are going to be consumers of this model. So they're written in ways that are not going to be super technical about the underlying modeling and just very digestible. So don't be afraid. Pick up some of these resources, read more about it, attend more talks, and if you have questions and concerns about it, I'm happy to answer those.
Great. Well, thank you so much for your time. Thank you to all of our attendees for joining us today. We hope to see you at future webinars. And if you are not yet an ADAA member, we invite you to become one to get access to free webinars such as this one. Dr. Kazarski, thank you so much for joining us today. You have a wonderful day, and thank you, everyone.
Thank you so much for having me.
Bye.